I want to give a brief overview of our department. We have 4 professors and 2 associate professors and 27 residents. We are working in 4 units headed by Dr. Ricky Mathur, Dr. Rajat Jangir, Dr. Anand Sharma and Dr. Sandeep Kumar. We have done around 1700 surgeries, major surgeries in last year, including pelvic surgeries. Around 200 of them we have performed in last 4 years. And complex shoulder surgeries, complex trauma like posterior flexor dislocation, and heavy arthroplasty and reverse shoulder replacement. And among spine, we are doing scoliosis surgeries and other spinal surgeries. These are the various complex orthopedic surgeries we have performed. In replacement, we are doing uni and total knee replacement and revision replacement, unlike that in hip and shoulder also. And we have 4 or 5 arthroscopic surgeons and regularly doing arthroscopy. Around 225 surgeries were done in the last 1 year. With the help of various departments of SRCC, we are regularly doing onco surgeries. We have done 5 ECRTs and 30 limb salvage surgeries. And in AVN, PHR is the gold standard, but we have been able to preserve the joint by vascularized fibular graft. And these are the various publications by our faculty in national and international journals. Dr. Rajat Jangir has represented Indian team as a sports surgeon in Rio Olympic. Dr. Sandeep has performed first minimally invasive total hip replacement in Rajasthan. Dr. Rajat Jangir was secretary Indian Cardiology Society from 19 to 22. Currently, he is the editor in Elsevier Journal of Orthopaedic Reports and fellowship committee member in International Cardiology Society. Now I invite Dr. Ritvik Singh to start the course.
Patient presents with a chief complaint of pain in the right knee for 2 years. Patient was asymptomatic for 2 years until experiencing pain which was insidious in onset, dull aching in nature over the entire aspect of the knee. Pain gradually worsened over the course of 2 years. Initially, the patient managed the pain with 1 to 2 tablets of NSAIDs and every 5 days, but the intensity of the pain increased, requiring daily NSAID use. The patient initially experienced pain only during high demand force activities such as running. However, over the past 6 months, the pain has worsened, and the patient now experiences difficulty even during low intensity activities like climbing stairs and even during prolonged sitting. This escalation in pain management coincided with a decline in the patient's ability to participate in the sports activities such as boxing. The pain is relieved when leg is kept extended and worsens with the activity. There is no pain-free interval and no diurnal variation. The patient did not have any history of swelling, trauma, redness, fever, restriction of movements, loss of appetite, weight loss, or night sweats. There was no involvement of other joints. The patient in national level boxer occasionally took medication from nearby medical store and underwent physiotherapy for 4 months without relief from pain. And patient did follow the vegetarian diet, and there was no history of any addiction, and there was no significant family or past medical history associated with the patient. To summarize, this is a 23-year-old male with a 2-year history of pain in the anterior aspect of right knee, which increased to moderate intensity and increased on strenuous activity and relief when knee is kept in extension. At this point, I want to ask my fellow colleagues what could be the possible differential diagnosis based on the history.
It can be meniscus injury.
Yes, it could be meniscus injuries. It could be. Any more? Could be a possibility for the gout, but it's not evident. But we'll be coming to the differences over here. Any more of the questions? Coming to the inflammatory causes, patient athletic background suggests that overuse could lead to conditions such as quadriceps tendinosis or patellar tendinitis and synovitis. Additionally, swelling at the bursa could potentially indicate prepatellar bursitis. These inflammatory conditions should be considered in the differential diagnosis. Coming to the metabolic causes, gout, it usually involves small joints, first metatarsophalangeal joint, with redness over them and pain, but at this point should be considered as a differential. Coming to the pseudo gout, which also involves a single large joint with a history of pain, fits better to the diagnosis and kept as a differential over here. In India, infectious causes remains important consideration, but since our patient did not exhibit fever, the likelihood of the infection is reduced. Tuberculosis, for example, typically presents with a long history of the constitutional symptoms, such as weight loss and evening rise of temperature. Despite the absence of the contributing factors in this patient, TB will be included in our differential diagnosis. Due to the presence of subacute infective pathology, it tends to have slower progression with minimal symptoms. Pyogenic also kept as a differential in our case. Among the degenerative causes, chondromalacia is an important differential as the patient has a long history of playing sports with knee pain for the last 2 years, so it could be a possibility. Coming to the trauma, trauma remains a significant consideration despite absence of a history of a direct trauma, giving the patient application at a national level athlete. Potential causes could include undiagnosed meniscus or ligament tears, overlooked osteochondral fractures, most likely patella, or possibly chondral injuries. Coming to the neoplastic, the patient's long history remains an important factor, thus continues to be significant consideration in our differential diagnosis. Further data would be necessary to definitely rule out all the current potential differential diagnoses. The patient is well built, well nourished, and is conscious, alert, and cooperative. Vital signs including pulse, blood pressure, and respiratory rate were within normal ranges. There is no significant findings on the general examination. On examination of the right knee, muscle wasting is seen at the thigh and the calf as compared to the contralateral side. Skin is normal, there is no swelling, scars or sinuses present. The patella is positioned normally with the anterior superior iliac spine at the same level. There is no limb length discrepancy noted, no deformity is present. There is no swelling, scar or visible pulsation in the popliteal fossa. Temperature was normal compared to the other side. There was no superficial tenderness noted. Deep tenderness was positive at the medial facet of the patella. You can see here the deep tenderness was positive. And coming to the deep tenderness was checked on the various locations like lateral epicondyle, medial epicondyle, joint line, pes insurinus, lower pole of patella, tibial tuberosity, and fibular neck, all were negative, except the medial facet of the patella. The patellar joint test was positive, indicating potential patellofemoral joint pathology in our case. There was no evidence of synovial hypertrophy, abnormal pulsation, or swelling in the popliteal fossa. Additionally, the patellar tap test was negative in our case. Special test for ligament and meniscus stability yielded negative results in our case. Calf and thigh circumference showed a 1 cm reduction compared to the contralateral side. The thigh circumference was 50 cm on the affected, 51 on the normal, whereas the calf circumference was 32 on the affected and 33 on the normal. The instrument shown in this picture is a goniometer used to measure the angles. Quadriceps angle measured in our case is 14 degrees. There was no shortening or flexion deformity in the case. The intermalleolar distance was 2 cm and the contralateral distance measured was 0 cm. The patient's gait was normal, left knee range of motion was normal with flexion up to 135 degrees and extension up to 0 degrees. Rest of the system examination, nothing was significant. To summarize, we have a 23-year-old male with presenting pain over the anterior aspect of the knee, initially appearing during high-demand sports activities like running. Over the past 6 months, the pain has worsened and now affecting lower intensity activities like climbing stairs and prolonged sitting. The decline in the activity has impacted the patient's ability to participate in the sports, especially boxing. The pain is relieved at rest when leg is kept in the straight position. Tenderness is noted on the medial facet of the patella, accompanied by the positive patellar grind test. Additionally, there was 1 centimeter of muscle twisting observed at both thigh and calf. Among the blood tests, all parameters were in the normal ranges. Given the normal counts and absence of the elevated erythrocyte sedimentation and C-reactive protein, the possibility of the infection can be ruled out. And also normal serum uric acid infers low possibility of the gout. Again, at this point, I am going to ask my fellow colleagues what could be the possible differential based on history, clinical examination, and the lab diagnosis. Among the differential diagnosis of the inflammatory etiology, both quadriceps and patellar tendinitis were excluded based on the absence of the superficial tenderness over the respective tendon insertions. Additionally, the positive results of the active quadriceps test further supports exclusion of these conditions. While there was no evidence of the synovial hypertrophy, the potential presence of the synovitis remains a consideration at this point. So we'll be keeping synovitis as a differential. Coming to the prepatellar bursitis, the absence of both the swelling and tenderness over the bursa indicates exclusion from the current diagnostic conditions. Coming to the metabolic, with normal serum uric acid levels and normal erythrocyte sedimentation rate and C-reactive protein, leads to elimination of gout and pseudo-gout in the case. Regarding the possibility of the infective etiology, its likelihood appears remote given the absence of the characteristic features typically associated with infection. Infective conditions commonly manifest with a prolonged clinical history with constitutional symptoms like fever. There were no constitutional symptoms present in our case. Moreover, normal leukocyte count and erythrocyte sedimentation rate and C-reactive protein further supports exclusion of the infectious cause at this state of the disease. Coming to the degenerative causes, as the history reflects, anterior knee pain is a long history of positivity of the patellar grind test, and it suggests there could be differential degenerative properties in the cartilage, leading to chondromalacia remains a possibility in our case. Coming to the trauma, as a result of the special test for the meniscus and ligamental stability yielded negative results, meniscus and ligament injuries are ruled out. Coming to this trauma remains a significant consideration despite absence of the history of direct trauma in our case. Given the patient education at the national level athlete, repetitive micro trauma could be leads to overlooked osteochondral fractures, most likely patella, or possibly the chondral lesion at this point. They both will be continuing with us. Regarding the neoplastic etiology, the patient's long history remains an important factor, but even there is no swelling and absence of the constitutional symptoms, the possibility of the tumors cannot be ruled out at this point. Further investigations are essential to conclusively exclude all current potential differential diagnosis. We requested for the radiological workup, for which I invite Dr. Gandhi.
Good morning, everyone. So this is the radiograph knee, anterior posterior view and the lateral view, where all osseous structures appears normal. The joint space appears normal. There is no obvious evidence of joint diffusion or bony erosion, and there is no obvious evidence of soft tissue calcification and a soft tissue mass. Henceforth, as the radiograph of knee appears normal, so MRI knee was advised for further evaluation. But before we delve into the MRI knee findings, let's quickly discuss about the basic sequence which we usually do in musculoskeletal radiology. MRI knee protocol comprises a group of MRI sequences to routinely assess the knee for internal pathologies such as meniscal, ligament, and cartilage injury. Basically, proton density with or without fat saturation are usually the mainstay. A T1 sequence is usually included to facilitate the assessment of any incidental marrow or soft tissue lesion. Proton density weighted images are usually done for detailed anatomy, and the fat in it helps to delineate the structures better. Proton density fat saturation is the best sagittal sequence for meniscal tear detection, and fat saturation helps to reveal the fluid better, such as marrow edema, fat bed edema, etc. So here is the normal MRI knee PD sequence. You can appreciate patella, femur. We can also see the smooth and regular medial patellofestoral articular cartilage and the lateral patellofestoral articular cartilage. This is the proton density and proton density fat suppressed axial view MRI knee of our patient. What we can appreciate over is the focal full thickness cartilage defect at patellar ridge, measuring approximately 1 into 1 centimeter. And in PDFS, we can appreciate hyperintensity and focal underlying subcondyl edema. These are the sagittal acquisition, PDFS and PD sequence of our patient. In this also, we can appreciate focal full thickness cartilage defect and with underlying subcondyl edema. So, summing up the radiological findings, the radiological diagnosis was full thickness focal cartilage defect in patella. Now, I would request Dr. Ritvik to please continue the case.
Thank you, Dr. Arzoo, for a valuable input. Now, after the history, clinical examination, blood test, and radiological evaluation, we have our diagnosis. The diagnosis at hand is a focal chondral lesion of the patellar cartilage measuring 1 centimeter by 1 centimeter. The most likely cause of the cartilage damage is a repetitive microtrauma. Prior to initiating the management, I kindly request Dr. Aditi to provide further insights into structure and function of the articular cartilage.
Good morning, dignitaries. I'm Dr. Aditi Singh, first year resident in anatomy department. Today we are going to discuss on the topic cartilage. Cartilage is a special type of dense connective tissue designed to support, to bear weight, and to withstand tension, torsion, and bending. It is basically classified into three types: the hyaline cartilage, the elastic cartilage, and the fibrocartilage. Today we are going to discuss about one of the types of a hyaline cartilage, which we call as an articular cartilage. Articular cartilage is a type of hyaline cartilage without perichondrium. It has load-bearing surfaces of all synovial joints. It is a highly organized structure and quickly recovers its shape to withstand the multiple forces created during the movement. So we can say articular cartilage is a white rubbery substance that covers the end of the bones of any joint where two bony surfaces move against each other. It acts as a shock absorber and to protect the underlying bone. Basically, some peculiar features of the articular cartilage as we can see. Articular cartilage is basically composed of the chondrocytes, which take up to the 5% of the total volume of the cartilage. Each chondrocyte established a special microenvironment responsible for the turnover of extracellular matrix in the immediate vicinity, which is over around 95%. Basically, matrix is required to maintain the structure and function of the cartilage. Rest water content is around 65 to 85% and also contains the protoglycans, which is the protein polysaccharide, which is up to 10 to 20% of the wet weight. Protoglycans have a unique bond with water which allows articular cartilage to resist and to distribute the compressive forces. The fibers here mainly found are of collagen type 2, which make up to the 57 to 75% of the dry weight of the cartilage. One of the main unique features of the articular cartilage is it lacks blood vessels and nerves, so because of that, it has a limited healing potential due to the lack of vascularity. This diagram shows the collagen and the chondrocytic pattern of the articular cartilage, which is divided into zones. So the first zone we call a superficial or the tangential zone protects the deeper layers of the shear stress and makes up to 10 to 20% of the articular cartilage thickness. Here the collagen fibers are found to be mainly of type 2 and some of the fibers of type 9 and are packed tightly and arranged parallel to the articular cartilage. It contains relatively high number of flattened chondrocytes. Immediately to superficial, there is a transitional zone, which is the second zone, or we could call as a middle zone, which provides an anatomic and functional bridge between the superficial and the deep veins or deep zones. It represents around 40 to 60% of the total cartilage volume. It contains proteoglycans and thick collagen fibers organized obliquely to the chondrocytes, which are spherical in shape. Functionally, the middle zone is in the first line of resistance to the compressive forces. Now, the third zone or the deep zone providing the greater resistance to the comprehensive forces, where the collagen fibers are arranged perpendicular to the articular cartilage. Deep zones have the largest collagen fibers and have the highest protoglycan content and lowest water content up to the 30% in the articular cartilage volume. Here in the line, we have a tide mark line which basically distinguish between the deep zone and the calcified zones. Last not the least, articular cartilage lacks blood vessels and it has a very limited healing potential capacity due to its vascularity. Now, nutrition of the cartilage. Articular cartilage is a avascular tissue nourished by two potential pathways. One is the synovial fluid diffusion and one from subchondral bone vessels. Both the routes provide nutrition to the cartilage and plays a very crucial role in maintaining the normal cartilage hemostasis and its functions. Thank you. Now I hand over to Dr. Ritvik for further presentation.
I thank Dr. Aditi for her valuable inputs regarding the understanding of the structure of the cartilage and its functions. The lesion was classified according to the grading system of the International Cartilage Repair Society. Due to its extension into subchondral bone, we can see we categorize the lesion as grade 4, leading to definitive diagnosis of patellar chondral lesion grade 4. Considering our patient status as a national level athlete and treatment objectives are centered on facilitating early return to the sports, alleviating pain and enhancing functionality, the primary goal is to restore the smooth surface of the articular cartilage and align its biochemical and biomechanical properties to those of the normal hyaline cartilage. Over the past century, various treatment options have been developed for addressing cartilage issues. These include arthroscopic debridement, which includes the formation of the fibrocartilage and serves as a palliative treatment for patients experiencing minimal symptoms. Coming to the second, marrow stimulation or microfracture, which promotes the formation of the fibrocartilage and is employed as a reparative procedure typically for patients with low demands and smaller lesions. Coming to the third, osteochondral autograft transplantation, which generates hyaline cartilage and serves as a reparative procedure suitable for both low and high demand patients with smaller lesions. Coming to the final one, which is the autologous chondrocyte implantation, recognized as the most advanced and regenerative among the procedures. These techniques lead to the formation of normal hyaline cartilage and is utilized for treating lesions ranging from small to large, including cases involving bone loss in high demand patients. Among the options considered, arthroscopic debridement and marrow stimulation are ruled out because they result in the formation of the fibrocartilage rather than hyaline cartilage, which is necessary for restoring the normal anatomy in a high demand patient. Coming to the osteochondral autograft transplantation is also not suitable in this case due to the specific nature of the lesion located at the median ridge, which complicates the restoration of the smooth articular surface. Therefore, the best treatment option in this scenario is the autologous chondrocyte implantation, which was chosen as the preferred treatment for achieving best outcome in our patient. The selected final procedure is the autologous chondrocyte implantation, which has evolved over the years into 3 generations. Initially, the first generation involved injecting autologous chondrocyte under a patch of periosteum, necessitating a 2-stage procedure, complicating including periosteal hypertrophy with bone formation, and it was not done in the case. The second generation, which involves injecting chondrocyte under a collagen patch, was also not done due to loosening of the patch and leakage of the chondrocytes. Finally, the third generation, the most advanced one, which represents the most advanced approach using fibrin glue with cultured chondrocytes, was chosen for the superior effectiveness and outcomes. Procedure was done in 2 stages. Both the stages were done under spinal anesthesia. The initial stage involving arthroscopic coupled with a biopsy and subsequently chondrocyte culture. Following this, a preparatory period of 4 weeks is mandated for the cultivation of autologous chondrocytes and then be processed to the stage 2. During the second stage, the debridement is performed alongside the implantation of the chondrocytes within the gel matrix. Subsequently, the patient went a structural rehabilitation regimen for the recovery and the functional outcome. The biopsy was carefully extracted from the superior aspect of the medial femoral condyle, which is the non-weight bearing area of the knee, thereby minimizing the risk of the complication related to cartilage loss. Here we can see the biopsy being taken, and biopsy specimen having it precisely measured, ensuring 3 millimeter of the cartilaginous graft with 3 millimeter of the osseous attached to it. It is being transported following extraction into its inner sterile wire and transported for the chondrocyte culture. The sample was collected from Mahatma Gandhi Medical College, Jaipur, and subsequently transported to Regrow Lab in Pune, Maharashtra, which is the only GMP certified lab in the country, ensuring that the cold chain is maintained throughout the transportation process. Chondrocytes were cultured in the laboratory, cell counts were measured during the process, and when the target cell count of achieved of 12 million autologous live cultured chondrocytes in 0.4 ml DMM solution, Develco modified legal medium and were notified at the end of the 4th week, and patient was notified and called for the second stage. Following receiving of the cultured chondrocyte, patient was called for the second stage of surgery. And now second stage of surgery is done while opening of the joint by medial parapatellar approach for mini arthrotomy. The stage 2 procedure comprises of 2 steps, primarily debridement, then the chondrocyte culture. Here we can see the cartilage defect is being measured. We can see it is measuring of 0.7 centimeter throughout all the sides. We measure the cartilage defect. We can see it is being measured throughout all the sides and it is 0.7 centimeter. Now, after measuring of the cartilaginous defect, we go towards the second stage of the process, which is the defect debridement of the cartilaginous defect. Defect is being debridement with a rim being created and with measuring of the lesion 1.2 by 1.2 centimeter with curettage up to the subchondral bone. After curettage, we see is there any loose cartilage present or loose or soft cartilage present around the lesion or not. We can see there are various parts of the soft cartilage presenting around the lesion where we can see probing with it, and we can see the final effect of the cartilage is much more than we anticipated in the beginning. After the loose cartilage removal, we have a final lesion measuring around removal of the loose cartilage has been done. You can see the final lesion which measures around 2 cm by 1.2 cm, which was earlier initial defect of 0.7 cm when we started before debridement. And now we can, after debriding of the lesion, we can move towards the second stage of the procedure, which is the chondrocyte implantation. Here we can see chondrocytes are being placed in the fibrin glue at the center of the defect. We fill the defect from the center to the periphery. This is the fashion we use in the process. From the center to the periphery, we use a drop by drop method. We fill one drop, then we ensure the previous drop is settled before pouring on the next drop to form the uniformity and overflow of the fibrin glue in chondrocytes. We can see this. We can see the defect is being filled by drop pressure from the center to the periphery, and we can see at the end the final defect has been completely being filled. You can see how meticulously the drops are being placed, single drop one by one after it. After waiting for 8 minutes, we check for the integrity and stability of the graft with continuous flexion extension movements of the knee. We do around 8 to 10 flexion extension movements in the knee to see the graft is placed on its place or not. If the graft dislodges during the process, we can repeat the same process again. But in our case, the graft was securely placed. After completing the procedure, we now close the wound with the application of the brace. This is the final result obtained at the end. So we can see the defect is completely filled and obliterated, maintaining the smooth surface of the articular cartilage. In our patient, the following post-op management was followed with dressing and static quadriceps exercises with hamstring and closed-chin knee bending exercises on day 2, which allowing the knee bending or achieving of 30 degrees by the end of the 7th day. On the 14th day, suture removal was done along with the partial weight bearing, achieving total goal of 60 degrees of knee flexion. Till day 21, 90 degrees of knee flexion was achieved, planned to increase to 120 degrees by 28 days, and we achieved that. After day 35, full knee bending was achieved with patient allowing to bear full weight on the knee. By the time of 1 year, the patient returned to the continuance to the sporting activity. For discussing the rehabilitation protocol in our patient from day 35 to 1 year, I would like to request Dr. Parnika from Department of
Good morning, everyone. As told by Dr. Ritvik about the surgery, now let's move on to the rehab phase. The rehab phase was divided into 7 phases. The first phase was the immediate post-op phase, which started from day 0 and ranged till 1 week. The first thing which what we did was to protect the graft as it was the initial phase. After that, we continued with the full extension brace and started with the knee flexion ranging from 0 to 30 degree. The next phase comprises was to restore the mobility of the patient, which ranged from 2 to 3 weeks. In this, the flexion which was on to 30 degrees, we increased that flexion to 60 degrees with passive knee extension. We introduced the patient with toe touch walker for his mobility. The third phase was strengthening, which ranged from 4 to 6 weeks. It included pain-free active knee flexion. We made the patient do knee flexion, which was pain-free, and it was of 125 degree. We performed hamstrings and quadriceps isometrics with the patient. Closed kinematic exercises were done, and recumbent cycling was also done. The fourth phase was independent movement, ranging from 7 to 12 weeks post-surgery. Open kinematic quadricep exercises were introduced to the patient. We did all the patellar mobilization, including all the directions. Isometrics were continued, and we introduced proprioception exercises to the patient. After this, the main goal was to return to the daily activity, which ranged from 3 to 6 months. We started with the gait training of the patient, cycling, and the open kinematic exercises were continued. Sixth phase was to introduce with the recreational activities, which ranged from 6 to 9 months. The patient was able to jog. By continuing the strengthening, we introduced with the sporting and the balance exercise to the patients. The last and final phase was to return to the full activity, that is to his sports. For that, which ranged from 9 to 12 months, we introduced with plyometric exercises like box jump, squat jump, and all the sports related activities which was essential for the patient. Thank you.
Thank you, Dr. Parnika, for your input. As we saw, such small defect underlying such a great complexity and importance of the articular cartilage with its non-healing properties. In the advancement of the newer technology for the articular cartilage repair, helping us to restore the normal cartilage of the joint. I'm happy to say, after having the follow-up of 2 years, our patient has underwent full recovery, and with the continuation of the sports as a boxer with no complaints of pain. For the literature review, I'd like to call Dr. Gandhi.
Very good morning to all of you. So from the anatomy of articular cartilage, we know that it is a very specialized structure. It is having a very limited healing potential because it lacks vascular supply, and also there is very less of a diffusion from the joint fluid, which leads to its nutrition. So the journey of articular cartilage repair, it started with a sentence by John Hunter in 1743 that the cartilage injury is very troublesome, and once injured, it is seldom repaired. There are many options for the cartilage repair. We have first option, that is debridement. We just remove the loose cartilage flax, so the patient is symptom free because of the mechanical impingement which was there has been removed. And the second option is doing the micro holes, micro punctures to the subchondral bone. It leads to escape of some of the marrow elements that leads to formation of a fibrocartilage. Another process is a replacement of the cartilage from the non-weight bearing portion, that is known as a osteochondral cylinder transfer technique. So in this process, you need to transfer the osteochondral cylinder from the non-weight bearing portion to the high demand weight bearing portion, wherein the defect is filled and you will get a hyaline cartilage. And another process which is known as autologous chondrocyte implantation. You take the biopsy of the chondrocyte, the cartilage, and you grow in the laboratory, then you implant it again. So The first two process, it leads to formation of a fibro cartilage which is having a collagen type 1, and it can be done for a low demand patient as well as for a smaller lesion, but the effects are not very durable. But in the last two procedures, osteochondral cylinder transfer and ACI, you get a hyaline cartilage, and this hyaline cartilage, the effects are very durable, and it can be done in patients with a high physical demand, as well as there is no size shape restrictions, especially for ACI. The autologous chondrocyte implantation, the first surgery was the concept was developed by Professor Metz Ritvik from Germany, and it was not well accepted at that time in 1994. He was called as an insane surgeon by his fellow colleague, as he removed the cartilage from the joint. He grown in the laboratory in artificial medium, then implanted again. At that time, it was not very popular. He was called as like an insane surgeon, but now he's the godfather for every cartilage surgeon in the world. From that, the ACI has evolved over a period of time from first generation to second generation, and we have used the third generation in this patient. The first generation, essentially, the chondrocyte was secured with a periosteal patch, and this periosteal patch has a tendency to get it hypertrophied, as well as you need to do a second procedure. So it was evolved to the second generation, that was the securing that with the collagen patch, but still there was a chances of escape of chondrocyte from that collagen patch. So the gel-based ACI is the most advanced one which we have used. So there are not many studies available for the autologous chondrocyte implantation. This is the study by Professor Matt Whitman. He's published his study, 5 years follow-up, all the cases from Europe. There were 14 centers from Europe. They had total 144 patients. That was done over a period of 20 years. So the number is not very much because of its limited indication as well as the cost factor. In the study, they have shown that it is better than micro fractures in terms of durability. And another study by Christopher Argalet from Europe again, he has shown 21 patients over a period of 12 years. Again, the durability of the repair is quite good. So from all 3-4 studies, it can be concluded that the autologous chondrocyte implantation leads to a hyaline cartilage repair, provides excellent congruency, and there is no size and shape restriction. So it's a very good option, especially for a high demand athlete. We have shown our athletes suffering from pain since 2 years and not able to participate in sports for 6 months. So this is the follow-up of this patient. He is back to competitive sports since last 3 years, and recently he has participated in the international event that has been done at Thailand, and he has sent me these videos recently. The first video, the white shirt, the second video, the shirtless man, and in the third video, the blue one. So he is participating even at the international level since last 4 years. No pain, all range of motion good for this patient. So where we stand in this cartilage repair surgeries. There are 3-4 centers in India which are doing the cartilage repair surgery like this. We have done one case of ACI, the autologous chondrocyte implantation. One case is pending due to we have deferred this patient because the pathology is progressive in this patient. Once the pathology settles in, we have a definitive lesion size, then we do the ACI in this patient. We have done 23 cases of osteochondral cylinder transfer for different indications, and we have also done 50 cases of microfractures. When you do some ligamental surgery, there is a small cartilage lesion that can be dealt with the microfracture surgery. Why there are less number of surgeries done for autologous chondrocyte implantation? Reason number one is the indication. The indications are very limited. You can do it only for a focal condyle lesion. It cannot be done for a degenerative lesion like an osteoarthritis, where you have a full lesion everywhere in the knee. You have to be very specific for a focal condyle lesion. That is the one thing. Second thing is the cost factor. The cost is approximately 2 lakh rupees for a culture and another 2 lakh rupees for a surgery, 2-stage surgery. So it's 4 lakh rupees. That's why the less number is being done. Once we'll get at least 10 patients in all of the center, we'll get 35-40 cases, then we'll try to publish a multi-center study like the Europe studies, which have been done in a multi-center manner. So, other than the cartilage repair surgery, we have also done the surgeries in athletes like a professional football player, the professional taekwondo player. They have won medals as well as for the international national event as well. The national gymnastic player, football player, badminton player, kabaddi player, hockey player. These are different athletes which have been operated for the ligamental surgery and meniscus repair surgery at our center. I am fortunate enough to serve as Secretary of Indian Cartilage Society as well as a fellowship committee member of the International Cartilage Repair Society. And at the outset, I would like to thank the management of Mahatma Gandhi Hospital for providing us with such facility to be able to work with these patients, as well as the Department of Radiology for their support, Department of Anatomy, and Department of Anesthesia specifically for their support during the surgery. The Department of Physiotherapy for providing the care to the patient post-operatively, and special thanks to CCR Review Committee for providing their inputs, sparing their time for presentation of this case. Thank you.